Hello, welcome back everyone. Dietary interventions are recommended as one of the high priority in the WHO's revised guidelines for a positive pregnancy experience. Welcome to the fifth session of the Technical e-Dialogue series on maternal nutrition. I am your host, Dr. Rajni Peter. We truly appreciate you joining us today as we discuss a very important topic, maternal diets and nutrition counseling. National Institute of Nutrition, UNICEF, and FOXI are hosting the monthly Technical e-Dialogue series on maternal nutrition from January 2021 with the theme Strengthening Maternal Nutrition Assessment and Services in Antenatal Care in India. We are grateful to our partner Alive and Thrive, Dr. Sebanti and her team, and Dr. Vani Sethi from UNICEF for working on this topic and giving this e-dialogue a very concrete shape. We thank our other partners, Sight and Life, Nutrition International, Society for Applied Studies, and Institute of Economic Growth for their cooperation and support. Today, a team of renowned researchers and specialists in the field has joined us. If you have any questions, please do post them in the Q&A box. Now let me invite Dr. Bharti Kulkarni, convener of the Maternal Nutrition Technical Series. Madam is a scientist and head of the Department of Clinical Division at National Institute of Nutrition. Her key research areas are maternal and child nutrition, anemia, body composition, developmental origins of health and disease. Please take over the session. Thank you.
Thank you, Rajani. Good evening, everyone. I'm very happy to welcome you all to the fifth webinar in the series of maternal technical e-dialogues, monthly e-dialogues. We started in January, and some of you would have attended our previous sessions. We had very important sessions on maternal thinness and maternal obesity in the months of January and February. Followed by this, we had a very interesting webinar on women's groups and how they can be used for improving maternal nutrition. We also dealt with a very important topic of maternal mental well-being, which is currently a need of the hour, especially during the pandemic. Following this, now we are in our fifth webinar, and this deals with a very important issue of maternal diets. We have been following a very consistent pattern for our webinars. In the first 1 hour, we have presentations by eminent experts in the field who review the evidence on the prevalence of the nutritional problems, what are the existing knowledge gaps, and what are the interventions which have been used in the past. Followed by that, next hour is devoted to panel discussion. We have eminent panelists who will be giving their perspective on what are the solutions that can be taken forward in this area. Usually the panelists include a mix of clinicians, public health experts, researchers, as well as program implementers. So today also we will be having the webinar in the similar structure. First 1 hour of presentations followed by panel discussion. And we are dealing with a very important issue of maternal diets. Its importance cannot be overemphasized. Even then, we have important knowledge gaps, and we need to understand more about the nutrient requirements of pregnant women. What are the strategies which can be taken up to scale? How the clinicians deal with the problems of improving maternal diets. We are very thankful to Dr. Sheila Veer and Dr. Neena Bhatia, who have joined us as chairs and co-chair for this important webinar, despite their busy schedule. I'll quickly introduce them first. Dr. Neena Bhatia is a senior specialist at Niti Aayog and associate professor at the Department of Food and Nutrition and senior technical advisor for National Center for Excellence and Research in Diets at Lady Irwin College, New Delhi. Her research interests include public health nutrition, diet counseling, and epidemiological research, as well as implementation and evaluation of public health nutrition programs. We are also honored to have Dr. Sheila Veer with us. She is the founder director of Public Health Nutrition and Development Center, Delhi. She's one of India's leading public health nutrition experts and requires no introduction to this group. She has extensive experience of working with UNICEF, Government of India, state governments, various national institutes and international agencies, and she has contributed significantly to formulation of national level policies and action plans for malnutrition, for alleviating malnutrition, and also contributed to development and execution of strategies for advocacy, communication, and training of frontline workers in health and ICDS across India. I thank you, both of you, for sparing your time and joining us. First, I would request Dr. Neena to give her opening remarks. Thank you. Over to you, Dr. Neena.
So, good evening, everyone, and thanks for having me for this seminar today. It is on a very important topic and an area of research that I have, been associated with. So, my thanks to the organizers, NIN, UNICEF, Foxy, and FIGO team for inviting me to be here. It's absolutely my pleasure to be hearing about the maternal diets and in nutrition counseling for the diets. Just Diets. I am. We started. I mean, we can. It cannot be overemphasized that the diet for maternal diet is important for mother's own well-being as well as for the well-being of the pregnancy outcome. And India, with its triple burden of malnutrition, now has to kind of strategize to be able to look after both underweight, overweight mothers, pregnant mothers, as well as as well as to look after micronutrient malnutrition. And we know that findings from NFHS5 for anemia and other aspects are not very encouraging at this point of time, although the program has not been fully rolled out. Government of India is really working towards improving maternal nutrition, and the recently launched Poshan 2 mission Poshan 2 also has as its focus on ensuring adequate and appropriate diets through SNP for pregnant, lactating, and adolescent girls at Anganwadi centers. It also has focused on it is trying to create an environment where we kind of improve from excess to utilization. So there is a lot of emphasis on dietary diversity and on ensuring that there are nutri gardens, and there are for local fruit forests that ensure long-term diverse diet adequacy. At the same time, there is a lot of emphasis on now shifting from just SNP to also to hot cooked meals in many Anganwadi areas, where, like the examples, successful examples from some of the states like Chhattisgarh and other states who have implemented maternal hot cooked meals at Anganwadi, is to use them for providing nutrition to the pregnant and lactating mothers, and also use them as an opportunity for giving nutrition counseling to these mothers. It actually focuses also on involving local foods in the planning of the diets, and also local people, panchayats and community volunteers and food soldiers, that can drive campaigns like Eat Right campaign and develop a sense of community ownership and responsibility. It has three core elements: on governance, on convergence, and on capacity building. And Poshan Tracker, which is the new avatar of Poshan CAS that was implemented as part of Poshan Abhiyan, is now operational, and it tracks last mile delivery of home cooked food, THR, children who are weighed. Even there is a provision for supply chain quality testing under district magistrate, and on food safety there is a lot of emphasis. At the same time, there is a lot of emphasis on capacity building of Anganwadi workers in domain skilling, location of specific nutrition education to the locations, and capacity building for quality processes, convergence across ministries, as earlier Avtaro Poshan Abhiyan also continues, but there will be quality invigilators, grievance redressals, and rewards and recognition to incentivize functionaries and volunteers. Although the focus still remains on the first 1,000 days, but Question 2, tries to focus right from adolescent to post-birth, and up to 3 to 6 year old children, and on early, particularly emphasis on with 1,000 days. And portion 2, also will be really making districts the central unit where the implementation of these programs can take place. And district magistrate will be the nodal officer who will, have certain KPIs which will be monitorable and will be, looked after. And with all these changes, I think this seminar is really timely to be able to understand the importance of maternal diets and how we can, what is the research and evidence that through which we can really promote them. At Niti Aayog also, we are, considering the COVID and that many services under ICDS have been disrupted. We are also looking at technological solutions of providing counseling, of reaching out to beneficiaries. So last month only we launched repository of all nutrition education materials and counseling materials named Poshan Gyan, and it will have we encourage all partners to contribute resources and materials which are behaviorally based on behavioral insights of promoting a behavior change, and we are partners in this endeavor of improving diets. So with that, I think I leave it to the organizers to take the seminar further, and look forward to hearing each presentation and try to understand the evidence and take it forward. Thank you.
Thank you very much, Dr. Nina. I think this understanding about the Poshan 2 strategy is quite important for today's webinar. I now request Dr. Sheila to give her opening comments.
Thank you. I'm delighted to be here with on a discussion on this very important topic on maternal diet and counseling. Very timely indeed, because we are going to launch, I think government is launching Poshan Point 2. So I thought, let me reflect what has happened in the last 5 decades. Have we really moved on maternal diet? Are we really, are there a lot of gaps? And indeed, I'm surprised. Though a webinar is an opportunity to improve, to give inputs for maternal diet improvement, if we really reflect back since 1970, the programs have been concentrated on supplementary nutrition of ICDS. And it was first called supplementary nutrition. 1975, it became a part of ICDS, and it became a component of ICDS. And we started equating maternal nutrition with the supplementary nutrition that was being provided through ICDS, which is, and there were a lot of schools of thinking. One group thought, no, it was of no use because it was not reaching, not consuming. What I fail to find in the literature is its impact on stunting of pregnant women, a very critical documentation. What I'm happy to note is that there is today documentation on hot cooked meal that is provided through ICDS in some states. That is a good documentation, and that will help us to move forward. We have actually not substantially moved forward on maternal diet. We have had RDA for a long time, since 70s. We have, of course, introduced maternal child protection card, but the column on maternal weight gets left out. And maybe we need a slot on BMI now. We have also have pushed on issues through ICDS on Godh Bharai ceremony for counseling. We have also pushed a lot on vatikas and how vatikas could be used for food diversity, diet diversity. But really, are they being consumed, or we are not able to connect the production to the consumption? So there is seems to be a lot of development, yet a lot of gaps, which I think this webinar will help us to move forward. Then I thought, let me look at program implementation, what has happened in our country. Besides supplementary nutrition, I don't see much. I do see some happening on women collectives, because we have this Andhra Pradesh project, again, which is one hot cooked meal being provided to pregnant women with the participation of community. We also have PhD research work, which was done in Delhi Hospital, which is very interesting, which is a PhD research work on Safdarjung Hospital cross-sectional studies on what was the birth seasonality and birth weight, where it was argued that winter vegetables are consumed and the post-winter children are good birth weight. Besides that, I think we have not moved much on diversity except Poshan Mission, where we have Poshan Abhiyan, and we have this counseling added to Godh Bharai ceremony. We have a long way to go, especially when we have obesity and overweight coming, which this seminar has, this group has been discussing. I think that is one of the concerns which we'll be addressing in the seminar, because we have some states where over 40% women are overweight and overnourished. Do we have a common ICDS food supplement? That is one issue. But what is the diet? What should be the principles of diet? I don't think we can prepare diets for all states and all districts having a thali. I have my concerns, and I hope this webinar will help us to focus on the principles of diet that need to be followed, and how. That is what the counseling, how do we connect with ANC sessions, which is really missing, unfortunately, which I know this webinar will be directing attention to. It is not only ICDS, but very timely, because Poshan Point 2 is coming. And I have read the draft document, and I urge many more to read it and help in filling in the gaps, so that government may consider our inputs. And I think, I'm hoping at the end of the webinar, we are able, that Foxy leads us to, with other professionals, to come up with a policy guidelines on maternal diet. I think that would be help to advocate with the government to go ahead with the national guideline. But I think Foxy can take the lead with NI and UNICEF and other agencies. That is a profession, just the way IAP took for child feeding, why Foxy could take for maternal diet, as well as preconception diet, because we have to improve the weight. So with these words, I now leave for us to move ahead with the webinar of today. And I am again delighted to be with you all. Thank you very much.
Thank you very much, ma'am. Your presence is indeed inspiring, and your guidance will be valuable. I now hand over to Rajati to introduce our speakers. Thank you.
Thank you so much, Dr. Bharti. It is now time to begin today's deliberations. Today, we thought we'll start with a poll. It will be interesting to see what our audience opinions are on this important topic. So let me launch the poll. So in your opinion, which of the following will be the best strategy to improve dietary diversity of pregnant women in India? You can choose multiple options. Okay, most of you have voted now. So let me end the poll and share the results with you. So as you can see, 85% of our audience and the participants felt that counseling family members like husband and mother-in-law should be an important strategy to improve dietary diversity. And 77% felt dietary counseling of mothers have to be done at all visits, and 65% felt along with that food supplementation programs like take home rations and spot feeding for the vulnerable group is important, and about 50% felt that we should also include community mobilization efforts. So the results are very interesting. Thank you all for participating in this poll. So without delaying, let's get started with the presentations. It is my great privilege to introduce today's speakers. The first speaker is Dr. Tina Sanghvi, who will speak about improving maternal diets, a global perspective. Madam is the Senior Technical Director of Alive and Thrive program at Family Health International 360. Over 30 years, she has provided program support and served as Technical Director in International Nutrition, Micronutrients, Child Survival and Public Health for programs located in Africa, Asia and Latin America. Our second speaker will be Dr. Phuong Nguyen. She will be discussing the evidence of enablers and barriers in the impact pathway for improving maternal diets. Dr. Phuong is a Senior Research Fellow in the Poverty, Health and Nutrition Division at International Food Policy Research Institute. Her major research interests are maternal and child health and nutrition. Currently, she is the team leader of the data and evidence to support policy implementation component of Portion 2. We are very glad to have both of you as speakers for today. Without any further delay, let me invite Dr. Sanghvi for her presentation. Over to you, ma'am.
Good morning, everyone, and thank you so much. It is a real honor and privilege to participate in this very important e-dialogue on maternal diets and nutrition counseling. As was said before, my focus will be on the global perspective on what's happening in other countries. So for the last 6 years, I've been working with our country teams in 4 countries in depth and also at the global level, following and tracking what is happening with recommendations. So the 4 countries are Bangladesh, India, Burkina Faso, and Ethiopia. Next slide, please. So I'll try to touch upon some of these topics: the importance of dietary adequacy, recommendations, dietary patterns, strategies, and challenges. I will try to highlight what is the concern and preoccupation at the global level and in other countries, what is happening. Next slide. We all know this already, but it bears reminding that with each cycle of pregnancy and childbirth, nutritional reserves of women decline, and unless they are protected and replenished with improved dietary intakes, the impact remains over generations. So it is a very crucial long-term strategy, and if we miss this opportunity, the impacts are very serious and very long-term. Next slide. We already know the consequences of poor maternal nutrition are serious for the mother as well as for the child. So for women, it's lower work productivity and increased risk of maternal morbidity, poor birth outcomes, fetal losses, growth restriction, preterm delivery, undernutrition, and poor cognitive development among offspring, a long-term damage that happens. 1 out of every 5 stunting in lower middle-income countries is attributed to maternal malnutrition, and 1 out of 3 in South Asia. So when we try to do stunting reduction programs, we must start at least with women in pregnancy and, if possible, preconceptional as well. Finally, maternal deprivation predisposes to non-communicable diseases and adult chronic diseases, which are hugely expensive and a big drain on national health services. Next slide, please. According to WHO, maternal diets and dietary adequacy contributes to the Sustainable Development Goals, in particular these 4 goals: stunting, anemia, low birth weight, and wasting. Next slide. So what are the trends in terms of women's nutritional status from a global perspective? So on the one hand, anemia and underweight still affect very large numbers of women. On the other hand, overweight and obesity are rising rapidly. And you can see the bar graphs on the right. These are different countries, and the proportion of women who are in the overweight and obese categories in the last 2 successive DHS surveys, there's been a big jump. This is the percent of women who are more than 25 in terms of their BMI score, which puts them in the category of overweight or obese. So this is a very dangerous phenomena, and it seems to be playing out in a large number of countries. So the implications are that we need dual or multiple targeted strategies, also national averages or state averages, in fact, high variations within countries and within regions. So we need disaggregated and more granular data and more tailored strategies that can be aligned with the situation in each zone. It's no longer one size fits all. Next slide, please. So what are the global dietary recommendations? We all know already, but what has been preoccupying and what is of concern globally? Next slide. So the recommended diet in pregnancy is based on certain principles. And right now, the emphasis is on linking this to the BMI of the individual woman in early pregnancy or before pregnancy. So we first set the additional calories that the woman needs to consume in the first, second, and third trimesters. And this is based on the target weight gain for that woman, which is in turn based on her BMI in early or pre-pregnancy. WHO has categorized the BMI scores into 4: underweight, normal, overweight, and obese. And the targeted weight gain varies according to the BMI category that each woman falls under. And so the calories that are recommended for that woman should be, this is what is being recommended, should be driven by the targeted weight gain in each trimester of pregnancy for that individual mother. Now that we have the additional calories to be consumed and the total calories and weight gain to be achieved, we move to the balance of what is in the diet in terms of macronutrients like carbohydrate, fat, and protein. So the percent of total calories in the diet that come from carbohydrate, fat, and protein needs to fall under certain balanced proportions. Next, we want to be careful and advise and recommend women on what is the type of carbohydrate, what is the quality and type of fat, and what is the balance of protein in the diet. So you see how everything leads up to the BMI in terms of the total calories, and then the balance of macronutrients, and now the quality of these macronutrients has a big impact on the nutrition adequacy of, or the dietary adequacy of the woman. So having done that, we now look at the vitamin and mineral profile of the food, and we try to make it align with the recommended levels of different vitamins and minerals. And in this context, it's the dietary diversity score of 5 specific types of food categories that is the aim in recommending diets. So on the right side, we see that we are not only aiming for adequacy, but also safety. So there are 2 principles underlying safety. One is the elimination of all contaminants from food, and those are listed here in brackets under contaminants. And below that is we need to limit the amount of certain damaging types of categories of foods, and those are listed as well. So rising intake of sugar and salt is of great concern globally. And alcohol and smoking are considered unsafe and not recommended at all during pregnancy. Next slide, please. Can I have the next slide? So it all boils down to how well we can put together programs and practice our individual practices, clinical practice, for individualized dietary counseling. It's not a general, generic recommendation anymore. So on the left side in this slide, we see the counseling objectives, and we've been through that already. The diverse food groups that are highly recommended globally are listed there. And the last one is build confidence and self-efficacy. When we are counseling a pregnant woman, it's very crucial that she should feel, I can do this. I know how to do this. And that needs to be kept in mind so that we are recommending foods and a diet style that fits in with her means and with the cultural context and with her family preferences at the same time, that we are not recommending something which is making her feel that she can't do this, it's too much or it's too difficult. On the right side are the usual counseling steps, and the bolded ones are the ones that globally we find are the most common gaps. The assessment part of counseling, where we start counseling by assessing, particularly weight gain, is not being done, we find in our other countries and also globally. Restricting the number of messages and making sure that we cover the what and why of those 3 messages very well, not being done. Engaging the support of family members, also a weak point. And the tendency not to listen because our frontline counselors and advisors are overworked, overloaded, or maybe they're not held accountable for certain quality parameters. So they're not listening, not taking the time to listen to women. So recording the visit and making sure that we have set up a whole series of contacts is absolutely crucial for counseling to work. Next slide, please. So we already saw that beautiful dietary plate at the opening of this session from NIN. Globally, it's the left side of the plate that is the big problem. We are not able to see adequate vegetables in particular entering into the diet of women, especially during pregnancy. Next slide, please. So this is from the Lancet 2021. Women have several deficiencies of essential nutrients during their reproductive lives. In Nepal and Bangladesh, for example, almost 80% of women had more than 2 micronutrient deficiency at the outset of pregnancy. And there are high prevalence of deficits in B12 and D, iodine, zinc, folate, iron, etc. in diets in several lower middle income countries. Next slide. This is another study of 62 different researchers, women in 2nd and 3rd trimesters. And folic acid and iron intakes were most frequently low, followed by calcium and zinc. And the usual dietary pattern was heavily cereal-based. As I mentioned in the diet plate, cereal seems to overtake all the other components of the diet plate, and it pushes out, the cereals are pushing out those food products that contain vital nutrients in the diet. So in the next slide, we see this verification in our own work, which we do collaboratively with IFPRI. This is Bangladesh and Burkina Faso, and you can see the lower circle the pie graph, it's looking a bit distorted, but it was 72% of the diet was carbohydrate. In Bangladesh, 75%. And you know, the guidelines for carbohydrate is 45 to 65 maximum. This is the percent of calories that should come from carbohydrates. So we are well over and excessive. We are seeing excessive consumption in other countries in terms of carbohydrates. And that also has, it's hyperglycemic, and it has NCDs, the non-communicable disease implications, and it drives out the intake of protein, fat, vitamins, and minerals. So this is a big problem, is to control carbohydrate intake. Next slide, please. So what are the determinants? As we know that the family is all important in many settings. And again, whether it's East Africa, West Africa, Asia, East Asia, wherever we are, the husband is turning out to play a very crucial, pivotal role in assuring the nutrition and diet of pregnant women. And I would add that we, in our programming and strategies globally, when we look at how people are programming, they're not paying enough attention. They're not spending enough time with husbands. They're not investing enough money, program money on husbands. We're not finding ways to reach them. So the programming is not really following the evidence that is growing about the role of husbands in pregnant women's diets. Next slide, please. So Dr. Vani has very kindly helped to shape this presentation, as well as my colleagues, Dr. Shibanti and Dr. Fong. So here's one of those frameworks. This is on the drivers of food choice. Drivers of Food Choice is the name of a program at the University of Southern California. And it's worthwhile going to their website to see all the research that is helping to develop this kind of framework. So this is on the food sector side of what we need to keep in mind in terms of the food environment and how different factors at community, household, and market levels are shaping the food choices, which affect pregnant women's diet as well. So on the right side, you see that sidebar which says the design of programs should be based on selecting what is modifiable in each context. Of course, we need to know what are the main drivers, but select the ones that are modifiable in the program and focus on those, because it is impossible to try to address everything. We try to address everything and nothing gets done. So focus is very important, and the underlying principle of how do we select that is what is modifiable. And that is done through testing and tips, which is trials of improved practices and other strategies. Once we have these specific modifiable factors, we then look at the operational side of programming. And for that, we have a couple of frameworks. One is the socio-ecological model that Alive and Thrive has developed and worked very much in terms of the operational elements. The model itself has been around for decades and used in multiple sectors, but how to operationalize that model for nutrition was done by Alive and Thrive for infant and young child feeding. That applies very well to maternal diets as well for the community component of programs. Then we have the building blocks and quality of care frameworks of WHO for health system strengthening. So I would certainly recommend these frameworks as we go forward for programming. Next slide. So the strategies, they're driven by community support. You see the big arrow on the left. And we have to address the barriers and take the opportunities at individual and household levels. We need to address the system weaknesses and take the opportunities of those platforms, whether it's health system, food system, social protection system, market system, to reach pregnant women and enable them to follow the recommendations. And of course, the policy environment is very important. And we have frameworks and steps in the policy development process in the Alive and Thrive website as well. Next slide. So this is what the Lancet is saying. They've provided certain selected evidence and shown the shift of what is happening at the global level in terms of evidence. So previously, 2013, Lancet said fortification for folic acid. Now they're saying fortification for all micronutrient deficiencies. It's so widespread, and there are so many different micronutrients, not only folic acid, that is deficient. For maternal calcium supplementation, it was a universal recommendation. Now it is conditional on if there is low intake in an area, then we do calcium supplementation. Maternal balanced energy protein, or in other words, food supplementation, again, was generic before. Now it is only in those areas that have a high concentration of undernourished women, or for those families that are undernourished in a certain community. It's not a generic recommendation anymore. And this is, again, it's driven by concerns about the escalating overweight obesity problems overseas in different countries. And then previously there used to be multiple micronutrient supplements or iron folic acid. And now they've dropped the iron folic acid and they're recommending maternal multiple micronutrient supplementation. The next slide, please. So broadly speaking, there are 4 categories. The upper 2 categories are more national, regional, large-scale programs, nutrition education based on science, based on theoretical frameworks. And that is what we call social behavior change. It's not giving messages. It's really addressing the underlying factors and using those strategies that have worked in terms of changing behaviors. On the right side is food fortification, and another very large-scale program that can reach not only women or pregnant women, but all segments of society who are consuming those foods, because these deficiencies sometimes affect all the age groups. Nutrition supplements and cash or in-kind transfers are in the lower side, lower part of this slide, and those are relatively targeted strategies. So this is where you can modify and tailor the inputs according to where the problems are, except that iron folic acid is required across the board for all pregnant women. So whether we do it through multiple micronutrients or just IFA, that is the choice that the countries have. But the others are generally more targeted and conditional on where the problems are. And all of these require social behavior change. None of these have been effective without that component. Next slide. So no matter what combination of these strategies we choose, it is the diligent execution of the strategy that is emerging as most important for results. So we spend a lot of time on design. We spend a lot of time on developing job aids and tools and posters and flip charts and what have you. And then we don't spend enough time, this is what we're finding in other countries, on following up the diligent execution of our strategies. And how do we ensure a focus on diligent execution? We are finding that holding people responsible and accountable for coverage and quality and use of data through cycles of review and making adjustments. So once we commit to a strategy, we have to be very flexible and be ready to make changes every single month or every single week. As we find a problem, we have to fix it. We have to keep on adjusting the strategy and making sure that it remains focused on those coverage and quality, and I would say equitable coverage and quality in our programs. And that's not happening as much. A lot of money, time spent on design, not enough on diligent execution. Next slide, please. So this is just stepping back now and saying, you know, WHO, these are 3 infographics on the 3 SDGs, which are of great concern globally: stunting, anemia, low birth weight. So here we see that while maternal diets and improving maternal diets is absolutely central and a core element, by itself, we should not expect that improvements in diet alone will deliver the outcomes of stunting or anemia or low birth weight. And these 3 infographics go into some more specific details of what else needs to be packaged with programs that are aiming for these achievements. So in any case, if we focus on maternal diet improvement, our indicators should be about maternal diet improvement and not trying to prove that we have reduced anemia through maternal diet or stunting or low birth weight. Next slide, please. You already, this is very common. Everybody knows, all the field people in the audience know about these programs. Bottlenecks, I've just underlined two that we are finding in other countries, that their adequate platforms are not really being engaged. Those different programs that are reaching pregnant women, that have the capacity, the potential to reach pregnant women, are not being engaged in a strong way. And the managers of those programs are not being held accountable to reach out to all pregnant women in their catchment areas. Secondly, as I said before, weak execution, lack of data-driven adjustments, all through implementation. The data-driven adjustments never ever goes away. We just have to be flexible and be prepared to make those adjustments based on our data. So strengthening monitoring systems and the use of that monitoring data, very, very important. Next slide, please. You know, there are challenges at every level, whether it's the household, individual level, community level, or systems level. We should be prepared to deal with these challenges. And this is what we are looking for in our monitoring. We want to find where the gaps are so that we can fix it. We want to know what's happening. So our data systems need to be at all these levels, telling us what is working, where the gaps are, what needs to change. The next slide. So it's no surprise then that the least amount of progress in terms of the numbers of countries that are on track to meeting the SDG targets for maternal nutrition are the ones that are the most problematic. So the largest number of countries that are not on track, there's no progress, or the situation is worsening for anemia and low birth weight. And this is across 194 countries. The largest problem and where we are stuck is on the two SDGs that are most directly related to maternal nutrition. And we heard at the beginning of the presentation in the most recent Lancet how damaging that is for families, for communities, for regions, for countries. So clearly we need to shift priority and we need to do a better job with maternal nutrition. The next slide. This is simply a summary. Importance, lifelong, intergenerational, and it's very costly to ignore this problem. The recommendations are both global and country specific. Many are linked increasingly to body mass index. We have to aim for both adequacy and safety. Dietary patterns today is universal prevalence of micronutrient deficits in diets. And they're not being carefully linked to the BMI of the women. And there's an imbalance with excessive carbohydrate intake. And there's rising non-communicable disease risk through the increased consumption of things like salt and sugar and trans fats. The strategies can be universal or more targeted. Generally, combined packages are required both in the health and in the food systems, all of them packaged with social behavior change and understanding of what drives food choices and food consumption behavior. Finally, the challenges, knowledge. Most people don't even know about maternal diets in the countries where we have worked and in the data that's out there on knowledge. Health workers, agricultural extension agents, people who work in social protection, managers, policymakers, stakeholders in nutrition, the knowledge about maternal diet is lacking. And then there's food security and gender norms and system gaps that are huge and they override everything. So unless we are prepared to deal with this, and they can be addressed if designed carefully, we will not be able to make that breakthrough change in improving maternal nutrition, maternal diets. And how well we execute the programs, that will determine whether we see results. The design can be brilliant, but if it's not executed well, then we shouldn't expect to see results. Next slide. I want to thank you again for the opportunity to speak with you, and I look forward to hearing about and learning about India. Thank you.
Thank you, Dr. Tina, for that excellent presentation on the importance of dietary adequacy, recommendations, strategies, and challenges. Audience, please put down your questions in the Q&A section. Our experts will try to address them once. We'll also see if we can address one or two live once both presentations are over, but already we are slightly behind the schedule. So let's see how it goes. So let's proceed to the next presentation now. Dr. Fuong, please, can you take over?
Thank you. Can I share the screen in my computer?
Please go ahead.
Okay, thank you. Do you see my screen?
Yes, we can see your screen, ma'am.
Okay, thank you. So thank you for giving me the opportunity to present on this very important webinar. It's very honored to be here. And Dr. Tina already set the stage very well with the global evidence as well as strategy. So I will be more focused on India context. So in the presentation, I would like to talk about the problem of poor diet in India. What is the key determinant associated with suboptimal diet, and few evidence of program and strategy to improve maternal diets in India. So as you may already know that in India, the maternal undernutrition is still big public health concern. If we look on the left, it's about preconception situation. We can see that about a quarter of women in India enter pregnancy like underweight with BMI less than 18.5. About 40% of adolescent girls are underweight, and more than half of them are anemic. The pregnant woman situation even worse, with about half of pregnant women are anemic, and a third of them, even that, only a third of them consume about 100 of IFA every for each pregnancy. And the recommendation of weight gain, of course, based on BMI, but it's an average is about 10 to 12 kilograms. But on average in India, the pregnant woman only increase about 7 kilograms during pregnancy, and about 1 in every 5 children are born with low birth weight. So we can see that a lot of issues here that need to be tackled, and among the many determinants of maternal and child undernutrition, the diet is a key one that we need to address, like based on global evidence. For example, if we look at the figure here, the poor diets cause more death than any other risk factor. Worldwide in 2017, the poor diet can link about 11 million deaths. And if we look at the picture here, among many other causes like high blood pressure, tobacco, sugar, air pollution, or whatever it is, dietary risk is the first one that causes the most death based on the global data. How about India? India also observes very high rate of all diet-related deaths and disability. If you look at the map on the left, in India it's about 250 to 315 deaths per 1,000 population related to diet every year. And if you look at the right, the problem of diet related to disability per 1,000 population is much, much bigger. About more than 6,000 to nearly 9,000 daily per 1,100 population because of diet related in India. So dietary pattern in pregnancy and breastfeeding in women in India are very suboptimal. This one shows like weekly consumption based on MH4 data. So we can see that among fruit, egg, fish, meat, it all about less than about 40 to 50% of people consume that one. Milk, of course, only about at a level of more than 60-70%. But if we look at the daily consumption, it's much lower. The situation is about half of that. So and then vary some. If we look at the last two columns here, the fried food and the average aerated beverage is also on the way to increase. And that is the worrying for the problem of NCD also, or overweight obesity. However, the data on at the national level is very limited. At least NH4 or the National Survey India have some dietary pattern, but it do not have enough information to calculate the dietary diversity as well as the micronutrient or macronutrient intake. When we look at the data from one state is in UP, so this is study between IPRI and ANT in UP for the maternal nutrition. We can see here like more than half of women are vegetarian. But when we compare the dietary intake between vegetarian and non-vegetarian, we don't see much different. The key one we want to show here is either the women are vegetarian or non-vegetarian. Only about 20 or a little bit more than 20% of them are consume more than 5 food groups. Or on the other, what is achieve minimum dietary diversity for women. So it's so very low prevalence. So now I would like to come back to like, what is a determinant or what is a driver for the dietary intake. So globally, you already hear from Tina, but the determinant or the driver for the diet come from many factors, from food supply chain, from food environment like availability, affordability, and many other factors, to the individual factor like economic constraint, the cognitive, the aspirational, and to the consumer behavior. And on top of that, many other factors from environment, policy, global, or social culture context can affect the diet. So how about the situation in India? We can see that there's only few studies on the enabler and barrier for dietary diversity. So one of the study from ANT program shows that the enabler factor can come from both the supply side and the demand side. Just example, for the provider, we can see that if the provider get good training, get good job aids and supervision, and know how to use the data well, they can increase the knowledge related to dietary diversity or the how to counseling the woman, and it can improve their service provision and the counseling content during the counseling section with ANC that can help to improve the maternal diet. On the other hand, from demand side, if the user are exposed to service, they can improve the knowledge, the perception, and if they get the family support, they can also have a better maternal diet. On the other hand, we also see that there's many other barriers that can affect the adoption of the counseling or the intervention to the diet. Just example, the economic constraint is listed as the key one. The food availability in the area and in the household, the food preference, dependent on husband or mother and mother-in-law. I think it is a concept that happen in many South Asian countries. And then finally, the maternal knowledge, also like the barrier. If they don't understand, they don't follow the recommendation. The example from one ANT study also shows that, just example that if mother have a good knowledge, they are about 2 times more likely to consume the diverse diet. If they get good family and husband support, again, about 2 times more likely to get the diet. The socioeconomic can come out like the key one. And a lot of social culture practice can influence the woman diet. Just example like misconception, food taboo or restriction during the pregnancy, the gender norm, the education or the eat last and eat least. And also the women have very limited decision making on what to purchase or what to eat, because they mainly have to depend on the family or the husband or mother-in-law. The woman with higher education more likely to absorb the knowledge and then get the counseling service. And finally, the health service, there's a lot of bottleneck here because the ANC is considered the key platform for counseling with the pregnant woman, but there's a lot of missed opportunity where women go to ANC, but they didn't get enough the counseling. And the study shows that if they get counseling, they will try more likely to consume the diverse diet in the ANT study. The economic determinant of maternal diet is a key point that when we look at the data from NH4, we also see that the woman from the high SES class, they are more likely to consume the food with more diverse and also more like nutrient rich, such as milk or fruit. Of course, egg and fish and meat will depend on the vegetarian or non-vegetarian. So we didn't so much button here. But also warrior some is a beverage one with a sweetened beverage. It also agree with the high SES people. So it's something that in the counseling section, this one need to be really in one of the component, not only diverse diet, not only nutrient food, but also how to eat healthily. And in another study that shows that portability is a key issue here. In the one of study in UP, when we do the market survey and the cost of diet with the household, we can see that a lot of households, the food are unaffordable and they are not be able to do the nutritious food. Just example, when you see in the figure here is the percent of household income. If they are poor or very poor, they are not be able to afford the nutritious diet. The middle group also barely be able to afford it, and only the better off are be able to afford with the nutritious diet. So that is something that need to be really tickled with the SES when we consider the strategy for the diet counseling. So in India, there's a lot of program and strategy to try to improve the maternal diet. So here we list few of the program, just examples, the take-home ration or the hot cooked meal distribution, the diet counseling during antenatal care, or we can say behavioral change program, the micronutrient supplementation program, the food fortification, social safety net, including the cash transfer, and then also the nutrition sensitive agriculture. We will give some examples of each program here, except for the last one. So the evidence on the one full meal program have been several studies in some states with the one full meal program. Just example in Andhra Pradesh, Telangana, or Chhattisgarh or Gujarat, and also in Karnataka. So we do some kind of review about the program here, what objective a program in each area. So the evidence review shows that very limited available on this program. The study normally use a mixed method. There's 3 implementation research and 1 evaluation study. The scale of study vary, ranging from 2 blocks to a few districts. That means the scale is still very small. And the study is mainly focused on the implementation issue, but not much in impact evaluation to extend like what is the impact of program on maternal nutrition outcome or on birth weight. But the good news is this program have shown that it has several impact pathways to improve diet women or improve the outcome. Just example, the food pathway, they show that if the women are able to access to hot cooked meal program, they're more likely to visit AWC and consume hot cooked meal there. So that can increase the diverse intake or quantity of food, and they're more likely to use the service. The second pathway is that program can impact through the service pathways. That means when they go there, not only they consume food, but they more also get the counseling, the consumption of IFA and calcium, and deworming. And the last one is from this program, the woman can exchange the population, they can improve the knowledge and perception, and easily more likely to adopt health and nutrition service. So the program have a lot of potential, but the evidence still now limited and need more study and more evidence for that. A dietary counseling during ANC is a big component of behavioral change communication. And ANT program is a big one that conducted in UP with very systematic and strategy to try to improve diet through counseling. So the results show that even with a lot of program efforts and strategy, it only shows some small impact on the vegetable, vitamin A rich vegetable consumption, other vegetable and other fruit. And they also show some impact on the consumption of micronutrients like IFA and calcium. But if we consider the overall dietary diversity of a woman, the program did not show the impact. And it also, we didn't see the impact on micronutrient intake of different nutrients. So again, that here that behavioral change communication shows some modest impact, but it needs to combine with other strategy in order to improve the overall diet for women. Micronutrient supplementation have shown several impact in many areas, including the one in ANT, like we just mentioned, and also in BIHA. And the women who visit early ANC or for ANC visit, although who get ANC counseling, more likely to receive IFA or consume more than 90 IFA. So again, that's showing that the ANC platform is really important for counseling and also for both micronutrient supplementation and dietary counseling. The conditional carb transfer, we have one study conducted in Odisha with compare the women who receive the Mamanta carb transfer program. So there's several installment timing in different time of pregnancy, but we can see that here that the study shows that even if they only get any carb transfer, that at least one installment, they can be able to improve the household food insecurity, like reduce anxiety, reduce insufficient quantity, and reduce the quality and quantity. So the program have potential to improve food security in the household and have a potential on diet, but the outcome did not show the impact on diet yet. And finally, we also found that the food fortification program still have very limited. Here it shows that one of the study used the data from the Indian district level health survey that assess the impact of subsidized fortified wheat on anemia women in India women. So they compare the North India, that means Punjab, and the South India, Tamil Nadu, where they get the program, with the neighboring state without wheat fortification. So the result a little bit diversing. Just example, in North India, they didn't see the impact on anemia or hemoglobin, and the result I expected because the intervention mainly targets on non-poor household and demand for fortified wheat was low. But in the South, in Tamil Nadu, they found that it no impact on hemoglobin, but see some impact on anemia reduction, about 8 percentage point reduction. However, the result also a little bit unexpected because in Tamil Nadu, the consumption of wheat is very low because this area dominantly people consume rye. So that means that the evidence on fortification is still very limited and need much more impact on and much more research on that. So in summary, we can see that dietary intake in India are very suboptimal and contribute to the burden of maternal and child undernutrition. And the key gap here is the data gap are still a big issue here. I just quote one quote in the Global Nutrition here saying that if we do not know what people are eating, we will not be able to design the effective intervention to improve the woman diet. So there's really a call for more accountability and more quality diet data. We found that there's multiple supply and demand side factors can influence the maternal diet, but the evidence of different intervention is still very limited. And we suggest that same like global ones, there's a range of policy and multiple sectoral intervention are needed to promote healthy diet and improve the maternal health. Thank you all for your attention.
Thank you, Dr. Fuong, for the informative and engaging presentation. We are convinced that multi-sectoral interventions are needed to promote healthy diet for mothers. Apologies for not being able to do a live question answer session as we are running short of time. Our speakers are addressing your questions in the Q&A box. So may I request everyone to please check them out. If you have any further questions, please do post them in the Q&A box. Okay, and now it is time to launch our second poll. This one is about the content of dietary counseling. So let me launch the poll. In your opinion, which of the following would be an appropriate content for dietary counseling in pregnancy? Here also you can choose multiple answers. Okay, I will end the poll now and share the results with you. So as you can see, 90% of our participants felt that local food sources of nutrients should be a major content of dietary counseling. Along with that, constituents of balanced diet, and only 60% felt that consequences of over and undernutrition need to be included in the dietary counseling, as well as balancing the budget and available government scheme. Thank you everyone for participating in this poll. So this was very interesting, and without much delay, let's proceed to the second part of today's webinar, that is the panel discussion on research gaps and challenges in practice. We are fortunate to have Dr. Hema Divakar, who has taken time despite having other webinars. Madam is the Vice Chair of the FIGO PNCD Committee, a senior consultant obstetrician and gynecologist with more than 3 decades of experience and expertise in women's healthcare. She is the medical director of Divakar Specialty Hospital, Bengaluru. And it's my great pleasure to invite you, ma'am, to moderate today's panel. Over to you.
Thank you, Rajni. Namaskar to Bharti ji, Vani, and the very distinguished speakers in the first session and all our dear delegates. Can I have the next slide, Rajni? We have 4 very distinguished panelists with us. So let me begin in the reverse order. Why reverse? Because the COVID pandemic, ladies and gentlemen, has put everything topsy-turvy. So in keeping with that, we introduce you to Mr. Sujit Lingala. He is the manager and of the Technology and Entrepreneurship Foundation called the Sight and Life Foundation. And his belief is that an egg a day keeps many of the problems away. It is strange that we are speaking about nutrition so late in the armamentarium of many things related to health that we have ever been conversing with. So in keeping with that, the preventive healthcare, the inclusion of the egg in the menu, if I may say, he is a Columbia alumni who is leading the nutrition and livelihood projects that improve consumption of eggs. And not only this, he has led many campaigns for the adolescents in countries like Malawi and led the way ahead. As Tina said, diligent execution is the key. No matter what strategies and policies we devise, but it has to go out there in the field. So that is Sujit Lingala for you. Mr. Krishnakant, I have the proud privilege of introducing Krishnakant from Jharkhand, who has established a non-profit organization and is a secretary, founder and the secretary of the Abhivyakti Foundation. He is also the co-founder of the Alliance for Immunization and Health and the co-convener of Sukhar Virodhi Abhiyan, which means a drought action network, continually working on the food and security issues and innovated the Saral Usna rice parboiling technology. So it is with innovative methodologies that we need to reach the fortified food to the last mile. So that is Krishnakant for you. My very own beloved friend and colleague from Foxy, Dr. Vidya Topi, who is the chair of the Food and Drugs and Medical Legal Surgical Equipment Committee. And believe me that she has brought a sea change in the attitudes of all the clinicians of the country looking towards under and over nutrition in clinical practice and conducted many, many programs. She is the professor and head of department of OBGYN at the Al-Amin Medical College, Vijaypur, with over 3 decades of experience and has led many effective interventions, research programs, and the national, international initiatives and publications. Welcome, Vidya.
Thank you. Thank you. Namaste.
Last but not the least, the first speaker on our panel is Ms. Radhika. Dr. Ms. Radhika is a scientist and head and the Department of Dietetics of the ICMR NIN Hyderabad, to whom we owe much for putting us all together on this wonderful forum on the last Friday of every month. The major areas of research in public health, nutrition and clinical nutrition, with the key studies in the most important micronutrient and iron deficiencies like iron, zinc, vitamin A, among different vulnerable population subgroups, including infants and children, and the impact that it could have on the sensory evaluation and the food acceptability. So we begin with the first challenge thrown to our first speaker, Radhika, where we know that from state to state and even within the state, the food patterns are so diverse. So what has been your experience, both in terms of research and policy making, to give us a tailor-made sense of what should it be when we do the diet counseling, may it be across the entire life course on any age group? Radhika, please.
Yeah, very good evening to one and all. Am I audible?
Yes, Radhika.
Yeah. At the outset, I would like to thank the organizers for giving me the opportunity to be part of this distinguished panel and also listening to some very good information from the previous speakers. So I have put together a very small presentation. So I will try to be as brief as possible, and I will share the recent interventions that the NIN has contributed in the field of maternal nutrition and diets. Can you all see the slides?
Yes, yes, we can see.
So broadly, I will be talking about designing maternal diet strategies, diverse dietary patterns across regions in India. This presentation is being made on behalf of ICMR NIN, and I would also like to say that I was not involved in the team NIN which was working on constructing the maternal diets, but I will try to pass on the information as much as possible to you. It's not moving to the next slide.
Ma'am, do you like us to share for you? Okay.
Yeah. So, coming to what are healthy maternal women's diets, I think it should be balanced across all the food groups. It should be able to diversify by including a variety of foods. It should be safe, desirable, and acceptable. At the same time, accessible and affordable by mothers and families. And also, there should be an element of moderate and restrictive in terms of HFSS foods, that is the high fat, sugar, and salt foods. Restrictive in highly processed and refined foods, and there is a need to establish a strong connect with improved nutritional status appropriate to the needs of not only the pregnant and lactating women, but also during and after the periods of pregnancy and lactation. Now, coming to the important recent contribution from NIN is now the nutrient requirements for Indians have been revised, and it has been published in 2020. What I would like to stress over here is earlier the recommendations were more close to the RDAs, but now the recommendation also talks about the estimated average requirements, which are the population level requirements, and the recommended dietary allowances that essentially needs to be used at the individual level when you're doing the counseling, and the tolerable upper limits for most of the essential micronutrients, wherein we need to limit our intake below the cleaver to avoid any toxicity. And another concept which is there globally and has been recently introduced into the Indian RDA book is what is called as the acceptable macronutrient distribution range, which gives us the ideal proportions of contributions of energy from the three major macronutrients, that is the carbohydrates, proteins, and fat. And subsequent to the to devising the nutrient requirement, there is a need to come up with user-friendly dietary guidelines for Indians. So as part of the history, we have already published 2 dietary guidelines so far. And the third edition is currently under progress with the expert committee members. But in the interim, NIN has published a My Plate for the Day, which is easily translatable to the general public. This is based on a 2000 kilocalorie diet with the insights of how you can modify for different age groups. So all these are based on the principles of variety, moderation, and balance.
Radhika, can you come closer to the device and speak? Because there are many comments that the audio is feeble. Yeah.
Okay. Is it fine now?
Much better. Thank you.
Okay. One thing. I just give me 1 second.
Sure.
Is it fine now?
Yes, Radhika. Much better. Thank you.
There was some background noise which was intruding. Okay, now these are the latest nutrient requirements. So I have put forward what is the requirement for pregnant women, the lactating women, and more importantly, the women of reproductive age. So you have the EARs, the recommended dietary allowances, and TUL, along with the acceptable micronutrient distribution ranges that are recommended for these age groups. This is a very one brief slide that I have put together from the data that has been collected by the National Nutrition Monitoring Bureau in the rural areas. This data is based on a basic 24-hour recall. So this very clearly shows that the intake of almost all the food groups are suboptimal except for cereals and added sugar, which are actually more than what is required. So this is mainly contributing to the excess calorie intakes from cereals, that is mainly primarily carbs, and added sugars in terms of discretionary calories. And the previous elite speakers have already mentioned about the ill effects and the undesirable health consequences that can ensue when the proportion of balance is distorted, which is very evident in the Indian diets. And coming to how can you design healthy maternal or women's diets. So primarily we need to understand that we need to use appropriate measurement tools to elicit diet adequacy. And there is a need to follow the latest revised nutrient requirement guidelines that is published and available in the open source. And we need to follow the AMDR for ideal distribution of energy from carbs, proteins, and fats. This will help us to reduce the risk of chronic disorders on one hand, while on the other hand, it will improve the nutrient utilization and the desirable functional outcomes that we envisage. Then what is important to understand over here is we need to use the EAR as a norm for population groups when we are counseling, and RDA as a norm for individuals to reduce the risk of diet or nutrient inadequacies. So the ideal approach would be to fill the energy intake gaps such that the AMDRs are adjusted to the recommended proportions and the EARs of important nutrients are met at an affordable cost if you include the cost variable into the program. And here it is also pertinent to mention that if we are able to adjust the AMDRs to the recommended levels, it is likely that we will be provided with adequate amounts of most of the essential micronutrients. And another important thing to keep in mind is we need to plan diets within the tolerable upper limit to avoid toxicity. This is very important when there is routine use or excessive use of nutrient supplements, and when more than one food is fortified with the same nutrient. This has to be considered in sync with the increased requirements during different women's life stages. And we should keep in mind that the diets that would be designed will be suggestive and not prescriptive. It needs to be women-centric, as we are talking of women diets. And what also needs to be considered apart from women as an individual is to consider the other influences like the family, the peers and the service providers, the local market access and food availability, the workplace environment and the policy within the workplace and access to healthcare. And moreover, it is seen that the diets in India are strongly influenced by region, the food culture, and the social desirability. So we need to be cognizant of all these factors when the healthy maternal diets are designed. Now, another recent contribution of the Institute towards recommending different diets to the government of India, and this is also available for public use in the public domain, is diets have been constructed for pregnant women, and this has been shared with the ministries, and it is available on the WCD ministry web portal. And here the recommendations has been framed and designed for pregnant women who are normal weight, for pregnant women undernourished, as well as pregnant women who are overweight. So if you see, these are the different food groups. So it is quite a diverse food palette for these three variations. And there is a mention also of what needs to be taken if in terms of diet plan, if the woman is overweight, there is a need to reduce sugar, the refined, the cereal content, mainly the refined cereals, and the oil also should be used in moderation. While if the pregnant woman is undernourished, there is a suggestion that there needs to be an increased intake of pulses, oils, and nuts. This is basically to provide more quality protein and more healthy fats, which will also contribute to other nutrient intakes as well as utilization within the body. So the points that have been considered while designing the diets was the types of recipes, the time of consumption and frequency may vary according to the region and the cultural preferences and convenience. But what is essential is that the amounts that is suggested in the diets need to be followed to meet the adequate dietary requirements. And also, since this was made for the supplementary program where the use of double fortified salt is mandatory, there is a suggestion in that regard. And for generally, there is a suggestion that the salt should be reduced to less than 5 grams per day in line with the WHO recommendations. And the cereals may be replaced twice or thrice per week with millets to improve the within food group diversity, and also to use as much as whole grain and less polished grain But what we also need to consider here is there is a need to counsel them with appropriate pre-processing and processing procedures to make the nutrients more bioavailable, because it is well known that there are quite some inhibitors in whole grains that might reduce the utilization and uptake of minerals such as iron, zinc, or calcium. And the diets have been suggested keeping in view both the vegetarian and the non-vegetarian population. But if the population is a vegetarian population, they may replace the quantity of the non-vegetarian and the animal source food of the non-vegetarian kind with 30 grams of pulse or honey. And since it is not feasible or not logistically possible to consume flesh foods every day, this can be consumed in a frequency of 2 to 3 times per week. And these diets have been designed keeping in mind that probably it will help the woman to gain minimum of 10 kgs if she is normal, or at least 13 kgs if she is undernourished, and around 7 to 10 kgs if she is overweight. And keeping all these in mind, there were region-specific diets designed for 6 different regions in the country: the north, south, east, west, central, and the northeast. Just as an example, this is the following menu which has been suggested basically for South Indians. It includes almost, I think, 7 meal types, which 3 major meals and 2 small snacks and 2 small beverages, which are having quite a diverse food categories, addressing each of the food groups that have been presented before. And also this will also take care of having frequent meals in smaller quantities. So now these are the basic diet charts that have been proposed for the normal, undernourished, and overweight pregnant women. I am very sorry about the busy slide, but I will just project the links that to which you can have access to this material. And a list of food options by regions has also been clearly mentioned in the guidelines, where you can exchange one for the other for at different meal times as well as at different food group categories. These are the web links that I was referring to. You can access the diet plan that has been made for different regions through these web links. And there is a mention of do's and don'ts that has to be also considered when we are talking about maternal rights for pregnant women. Coming to the don'ts, there are strict instructions laid down where there is a need to avoid smoking, chewing tobacco, consuming alcohol, consuming carbonated beverages or sugar sweetened beverages, eating cooked foods which are made from hydrogenated fat, and also on some of the good practices that needs to be followed when we are constructing diets, or also for the lifestyle practices. Coming to research gaps, it is evident even from the other speakers' talks that there is limited BCC or interventions on feasible healthy diets for women at all life stages, including pregnant and lactating. And also there's a very recent advancing nutrition paper that has been published by USAID, which has highlighted some very important gaps where there is an overarching limitation in research in terms of limited information being available in the women of reproductive age compared to other health and nutrition domains like IBCA, pregnant and lactating women, adolescents, or WASH. So there is a glaring research gap in women outside the pregnant and lactating stages, like the women in reproductive age, who are a very important subgroup, not only need to improve their diets and health, but also to the future generations. And there is very limited research on other modifiable factors because more focus is on women's individual factors. There is a need to reconcentrate on factors of the social factors, the immediate household level factors, the immediate environments, and the existing policies that are currently existing. In addition to that, there is limited research on influences for supportive actions for the women to access healthy diets. They include the family, the peers, the community leaders, etc. And last but not the least, there is more research required on nutrition sensitive interventions like agriculture or the local markets or the access to foods in these markets, the work environment regulations, and the media to make sure that the women have access to good healthy diets. And the key takeaways for the discussion is it is critical to ensure that all women in all life stages have a healthy diet to fill the requirements of essential nutrients basically, and adjusting AMDRs to the recommended proportions. There is a need to refocus on BCC resources and interventions to support the healthy diets through all stages of the woman's life, and there is a need to address the immediate and the distant enabling environment for the success of these diets. And as we've already said, there are critical gaps in the quality of the content and the number of factors. There is a need to conduct quality research to develop and test new BCC or IEC materials and interventions to bridge this gap. On one hand, while there is a need to improve and strengthen concerted efforts to adapt and use existing resources. And in addition to these, there is a need to complement the healthy diets with adequate physical activity, quality sleep, quality healthcare, and avoid stress. That's it. Thank you.
Thank you so much, Dr. Radhika, for such a brilliant presentation, because the poll just revealed that, we need to pay attention to the local resources and the food that are relevant in the local context. So this was so much in keeping with that. Just one quick question before I move on. You see the whole chart and local resources, South Indian, North Indian, vegetarian, non-vegetarian, sorted. But obese pregnant patient is now in front of you. Can you just tell us a quick fix method of how you will quickly change some things in the recommendation to suit obese pregnant women? How do we as clinicians do it very, very quickly?
First and foremost, what is primarily suggested is to straight away reduce the calories, dietary energy to less than 10% of what is recommended. And for this, there is a suggestion that we need to reduce the amount of fat intake, the amount of refined carbs intake, and the amount of the nuts and oil seeds. Keeping all the others
so much,
because they are providers of very good nutrients.
Okay, and yeah, thank you so much. And moving forward, because of the availability of technology, maybe all of these, the Healthify Me and other apps which come, the correct inputs by experts like yourselves, if we collaborate, I think it'll go a long way for the generation next to sort out for themselves of what is best for them. So thank you, Radhika. Again, we move on now to Dr. Vidya Tobbi.
She is a very busy practitioner, and there are a lot of cases in the Al-Amin Medical College. She's handling an ectopic, and there is already a fetal distress waiting there, and she doesn't have the luxury of a dietitian as such. And there is so much to do. So how do you prioritize the maternal diet counseling in clinical practice? Is it a priority at all for most of the clinicians who are shrouded with so many emergency kind of situations on top of all of that, the COVID as well? Vidya.
Yeah. Thank you very much, Hema. And really, it is a thought-provoking question for all of us, all the clinicians. And always we tell that nutrition is our backbone, right? So nutrition forms the base, and nutrition is our things we want to treat. Okay. So I'm just having a small presentation, but this, I was not knowing that I have to do presentation, but I did in a hurry. So when we should start really to intervene? That is a big question for the clinicians. Actually, it should start from the adolescent. Many of the clinicians, they have adolescent clinic. So when we say that the mother should, means a woman should enter into the pregnancy, a healthy pregnancy, our interventions rightly, we should start in the pre-conceptional period. So what a clinician should know is the nutritional risks, and what are the micronutrient deficiencies, what is malnutrition. We all this study in the community level, or we interventions we know, but as you tell us that we have to tackle many other things as a obstetrician, and we cannot, each one of us, we cannot afford to have a nutritionist at our place. So what we have to know is what nutrition advice for the specific conditions one can give. So one has to assess the nutrition status, means one should know the nutritional assessment, identification of nutrition risk, including, as you said, the obesity or underweight. We have to screen for anemia, other micronutrient deficiencies, adequacy or quality of the diet what she consumes. So we should have a recall of her diet for what she is eating right now. Then we have to tackle about the most of our women are also in the rural areas and other, as we have both the things, underweight as well as overweight. So we get the underweight woman with so much anemia prevalent, 80% of our women are anemic. So one should have the counseling strategies for the balanced and diverse diet, consumption of iron and folic acid rich food, and especially the nutrient dense food supplementation for the underweight woman. Vitamin minerals, as we have heard a lot from the previous speakers, and Dr. Radhika has given so many charts, what we require, what we know, so much jumbling in our brain. What exactly when in our busy clinic, a woman comes in, we have to have all this history, her nutritional status, and about her anemia, everything we have to tackle in 15 minutes. That is very difficult. So we should know all the interventions during preconception period. And what I want to say is it feasible for our country like India to create a separate infrastructure at the periphery, especially at the periphery, providing education for the nutrition promotion to the community? So there comes the role of clinicians. So we are going to train from FOXY, IAP, they have come together. And also we can Alive and Thrive, or everybody has come, even PHFI. So we are making a module where we can train all the clinicians. So this history of nutrition programs has various phases like clinical phase, food production, community development phase, and it is passing through various multi-sectoral phase on emphasis on the social economics of malnutrition. Malnutrition is not only undernutrition, it is overnutrition. And as it was discussed by previous speakers, really every clinician, they have the knowledge of what we are going to tell to our patient. There is a diet diversity, and we should know what is a local available diet, the counseling content, and the cost of diet. Everything should be addressed at one place. And also we have the great responsibility for the prevention of micronutrient deficiencies and anemia. And we have to increase the woman's access to at least the basic nutrition and health services. This is a very big task, I must say. And there are many inputs which are required from various allied fields for control, prevention of malnutrition. Education is very important, we say, but how to impart that education is also very, very important. Integrated nutrition education is there, cultural factors are there. We have to address the economic distortions, human inequalities, also gender bias, social injustice. These are the other factors that a clinician cannot tackle. Now, the counseling should be at the educational level, economical level, food availability. Then there are various aspects of the health preventive services. And the most important is the population size. Whenever we are addressing a woman who is coming from her family size is only 12 to 15 members in her family, what we are going to address to them? And there are various other strategies like midday meals and all, but how much nutrition we are going to provide? That is very important. So what is nutrition education, nutrition counseling, and how to make this counseling effective? Nutrition care plans, can nutrition counseling focus on, and the various different groups like Hema was telling about the obese patients, undernutrition, there are different groups. And also very important is WASH, that is water, sanitation and hygiene, which are to be addressed simultaneously. So these are the various strategies, and how to counsel is also a very tactful thing. So everybody cannot counsel, everybody's skills are different. So that's what we were talking of. And these are various tips of effective counseling. and everybody should have the charts at their place. So how to do that also, one should, it is very important. These are the various simplified charts, and I must congratulate Dr. Hema Divakar for taking me into this journey of nutrition and addressing the people and engaging in various platforms. This is very nice charts where we can do at the community level, how A&M as well as a medical officer can simply assess the woman for her nutrition. One is her nutrition assessment, what to give, how to counsel, and how most important is to classify the nutritional risk. The counseling part is very important as the classification of the nutritional risk, and what actions one should take for the nutritional risk is also very, very important. So we have to calculate BMI. We have to see what are the nutritional deficiencies like anemia we have to tackle, and then we have to counsel her for her nutritional guidance. So these are the things which one should put in the chart. What are your nutritional care plans? What is your nutritional diagnosis? What are the goals, and what are the goals met next time? And what advice you have given from variety of the foods from the various food groups. So the charts are available, but how to pick up from those charts? So we have to focus on, we have to teach our clinician to focus on essential nutrition action, critical nutrition action. We have to ask them to take ask about the patient's weight, BMI, everything, and also avoid the habits that can lead to the poor nutrition and poor health. So not only what she's eating, but how she's eating and what type of food she's eating. That food recall history is very important. So we have done, actually these are a few of the Hema slides only I'm using. She has given a very pictorial things in her presentation. So I picked from her presentation that these are the pictures of food groups with the healthy foods divided into sections to show recommended daily consumption, to counsel on various dietary diversity, and the food groups which are not same in all countries. So we cannot say that in Uttar Pradesh some food is available and in Karnataka different. So NIN has come out with the diet charts also. So what she should eat in breakfast. So these can be simplified and that can be put in the outside the OPD. So in general, they include primarily the macronutrients as well as micronutrients. So these are the simplified charts. You can see preconceptionally what she should eat, what food she should avoid, and how much proteins, what are the source of proteins, calcium and iron that can be put outside. And this is a simplified what is good iron, how to eat, and along with the other content of the food diversity and how you can improve the food quality and bioavailability of the various vitamins. So counseling is to how to increase in energy intake, not only that, but address the moderate malnutrition. So nutritional counseling for the pregnancy as well as people with the non-communicable diseases and obesity is very important. So for the undernutrition, you can use this chart. And severely undernutrient, when the woman comes with the undernutrition, what she should additionally eat. So how to improve the calorie content of the food, that is also very, very important. So those things, and the locally available, how we can make utilization of this. So overweight woman, what she should not eat. If this picture is put, no time, because as Hema told that all the obstetricians are very busy in their own schedule. So these are the various pictorial things they can put on the OPD, and we can train the clinician in that aspect. So these are the things one should remember. So basic counseling the clinician should know, or a health care provider, he should know that importance of good diet, one thing, dependence, how the fetus is affected, and how the mother is also affected by bad nourishment or good nourishment, diet during pregnancy, what she should eat, how much calorie intake she should, and what is the ideal weight gain during pregnancy, and the screening of various diseases like preeclampsia, as well as various non-communicable diseases, gestational diabetes, and ill effect of various malnutrition during pregnancy, unhealthy taboos, food fads. These are to be addressed, and need for the prenatal, natal, and postnatal care. So encouraging the use of maternal and child health care services and supplementary feeding as Anganwadi, at peripheral ASHA workers also we can train. Diet during lactation is very important, that need of supplements for first 1,000 days. Counseling for the food handler, and about the, you should also know about the food toxicity and the precaution, and how to cook, in what vessels they should put, so increase the food value. So one should also convey the message to community. Need for the nutrition education is there, and seeking the support of motivated people in the community who can help in nutrition education. And conveying the health and nutrition, we have to give the message to the community, and you should organize and taking part of various meetings. There are various NGOs, so we can have a group of women and you can address, you can call the any clinician also to take part. And how the importance of nutrition, it should be imbibed in the clinician's mind. We cannot give the prescription of diet, right? We cannot give like in tablets that you take this vitamin and E, but you can modify that, and you should imbibe these things on clinician's mind also. So another thing is at periphery, what is the problem is the staff adequacy and training and the motivation of the service provider at different levels of this. And there is always a staff turnover, right? So whenever there is a staff shortage in the corona pandemic, we are dealing with corona. There is no time to tell about the immunity and other things. So there is a staff shortage, turnover is more, and there are various gaps. So outpatient therapeutic programs can be run, community-based nutrition programs, and management of nutrition, blended, integrated nutrition, and one should have a counseling skill of these, all the people who are integrated in these services. So these are there, and you should give some training opportunities, mainly which depends on the partner or training provider organization objective rather than the need of the health sector. So it should come that it is very, very important part of women's health. There are various efforts. We have Anemia Mukt Bharat Poshan Abhiyan has come up, NIN, ICMS. So many organizations are coming up, and they are taking interest. And we as obstetrician and gynecologist, FOXY has come up also. And as a Food, Drugs and Medical Surgical Equipment Committee chairperson, we have taken initiative to form a certain guidelines as well as certain modules to train the clinicians. We know this is a FIGO checklist, and Dr. Hema was a part of these various programs. So this we have also imbibed. There are dietary guidelines of for the Indians, and we have circulated amongst various clinicians, and they told that it is very, very useful to take from these things. So there are various other new initiative also, like IIP has come up with the health phone, as Hema was telling, there is Healthify Me. Like that we can have for the pregnant woman, some apps, and one should know now what is the calorie content. If she tells that 1 katori of rice she is taking, how much calorie she is taking, what is the content of that, how many carbohydrates she is eating, what about the complex carbohydrates, what is the impact of those complex carbohydrates on her blood sugar, what is the glycemic index. These things clinicians should know. So clinician, when they tell, it comes from the horse's mouth, the woman definitely listens. And this is how the connecting to unconnected you can have. Even at the village levels, you can have the various recipes you can send to the woman. There are many aspects now nowadays you can reach to now, not only the clinicians, but to the patients. So there are various bridging the knowledge gaps. There are program strategies, policies, guidelines, health services, deliveries. Then there is a community mobilization, and definitely a behavioral change in clinicians as well as at the community level. So we aim at these all various levels to come to some conclusion, and definitely once all clinicians come together and they learn something about nutrition, that is what we aim at, definitely the woman is going to she will be benefited. And as we say that woman is healthy, the whole nation is healthy. So there are various checklists we can have for the healthcare provider, whether they have undergone, whether they have trained, whether they have taken the history properly, this checklist. And these are the various charts of calorie yields we can The another thing is these are like it is a community. We can discuss and ASHA workers, ANMs, everybody can discuss like certain non-communicable diseases. And as we were discussing about the fortification of various foods, we can also advise the fortification. And one should know that what fortification we can do in various foods. So thank you very much. This is a very emergency presentation I did. I was not knowing that I had to present.
Thank you, Vidya.
Thank
This
Thank
was
you.
pretty much exhaustive, even though it was done in an emergency, because most of us as OBGYNs do everything in an emergency. So it's in keeping with the spirit of OBs. Okay. You said that if it comes from horse's mouth, okay, then they will listen to it. I feel whether it comes from horse or a donkey or anything, long-standing myths and misconceptions are here to stay. Like there's one question in the chat box: papaya causes abortion. So, how will you address this? How can you convince women that?
See, papaya doesn't have any abortifacient. Papaya has got vitamin A. And so ripe papaya will not cause anything. This is a myth. And I usually advise my patient to eat papaya. So nothing happens if they eat papaya.
Okay, thank you so much. Then we move on to the next speaker on our distinguished panel. As Vidya said, that there is a lot that is going on in the clinician's mind, because they know that nutrition is important. They know that they don't have time. They are now taking newer courses by Foxy IAP, Alive and Thrive, etc. But how you can expand the time that is available to us is the key question. And the poll clearly showed that it is the local food and the balanced diet. These two we should focus on, and not most of the doctors are telling them, adverse consequences of what will happen if it's this or that. That is the tone in the way the clinician speaks. So that is the usual clinic scenario, which we have to change our mindset. So the single most point, which is important, is if the kind of food stuff that is presented to her is very different because of different agricultural practices. We now have Mr. Krishnakant, the founder of the Abhivakti Foundation. The single landmark initiative he has taken is a single window for the farmers. He's involved the community, which was much the tone of many speakers who said that we need their involvement. He's brought about many changes in the nutrition sensitive agricultural practices. And let's hear from him. What has he done? How has he done it? And what is the kind of impact that it has had? Because this will be a very revealing experience for us as clinicians, especially, and all the dietitians here. If this program can scale and escalate to Krishnakant beyond Jharkhand to the whole of India, we will really appreciate that. Please.
Thank you. Thank you, dear moderator, panelists, guests, and hosts. My apologies if in advance, if I get feeble or choked at any point of time, because I am still recovering. But let's start what I'm going to present. This is from the field-based experience that we designed and co-created with our partners, Welthunga Hilfe, UNICEF, and of course the community. So we interacted with the community and asked them one question, that why do we grow food? And there were 4 responses, very generic responses. One was that because we need to eat, so we are growing our food. Second was that we need money, and that's why we are growing food. Third is that to some small extent that we need to feed our animals as well, so we grow the food. And the 4th response was, I won't say bizarre, but it was very spontaneous, that we don't have any other skills, we are good at this, so we are doing it traditionally. Then the point was that, are any of the needs fulfilled from your farming? And answer was a big no. Neither the food, it was sufficient for the home in terms of diversity, neither the money was there, nor the animal were fed, nor it is creating employment. Next, please. Second, we looked at the sources of the diversity, from where people are getting their food, from their farms, from the PDS shop, from the market, shops, and ICDS, and of course from the commons, from the forest, from the river banks, from the fellows, and at times they were also lending from their neighbors. And each of the system has many weaknesses, as most of the speakers have already highlighted. So I won't repeat that. But then, yes, of course, the diversity is lost. And the common notion in case of farming is that who is a good farmer? So who is selling in truckloads? So that is a good farmer. Then while we discuss with the women and the mothers, asked about their preference or their vision, they say that I am a good farmer if I can offer you uh, 4 or 5 kinds of food, of course, of different groups. They are not very much aware of the different groups, but they say that if we can offer you any day you come, and of course we consume it, then I must say that I am a good farmer. So and second point is that as the earlier studies also showed that the lowest quintile has or they cannot afford the diverse food varieties, the diverse food, because the monetization is one problem, the money issue, cash. Second is that homegrown food, because it is easily available and everybody has some resources at their home. From there, the idea of nutrition sensitive integrated farming system came out. Next. So this I don't dare to present before you all. You all are aware of that. Next. This is the farm planning. What we do here while working with the communities, with the mothers, we try to assess, because two farms can never be identical. My and your farm cannot be identical. And when we talk about the culture, breaking the barriers of culture and other things, it is also about the respecting the culture and barriers, because there are something that must be respected. It is about the food choice. Some of the women are not eating chicken, but they are eating ducks. Likewise, some of them are veg on Tuesday and non-veg on Wednesday. So this is their food choice. And of course, in counseling, if there is a need of protein, extra instant animal protein, they can be convinced, but ultimate choice is theirs, that from which source they want to get it. So this at the bottom, we are seeing that there is a farm. Almost all the resources are available in the farm, and some small changes are making the difference to produce diverse kind of food. Next. So, and this diverse kind of food planning, this is based on the farm resource assessment, farm production assessment. It is linked with the dietary diversity score. So what are the gaps? These gaps are identified and accordingly the farm planning is made. And when we talk about the integrated farming system, we believe that every farm has 6 generic sources of production from where anything comes to home. One is the crop, second is the tree, third is birds, animals, aquatic products, and biodigesters. So these are the 6 production sources within the household. And the NCIPS approach, it helps to optimize the use of these resources for availability of nutrition, and of course also for the farm diversification, because on one hand it helps to address the climate risks. The diversification, it is as true or universal in case of other things as well. It saves people from the shocks. And here in the lower part of the slide, we see this one is a typical example of any family farm system. We have a rice field RF here, and we have one or two animals. Maybe in any particular favorable season, we have some vegetables. That's all. So from the rice field, the straw is fed to the animals. Rice comes to the home. A part of milk or meat comes to the house, and everything else is bought from the market. Some small changes, like in the rice field, we have a small ditch, we can see here. On the bank of this, we have some vegetables and some trees, of course, and then this ditch is used for cultivating fish. And this is the design, and this design has how it has worked, we will see it later. But we can see from the arrows that the nutrition availability at household level has increased many more times. It is contributing to the nutrition availability at the household, diversity, and of course, income. Next, please. Can we move? Yeah. So when we talk about the integrated farming, in case of the green revolution, we used some of the measures and later realized that no, this cannot be sustainable. Of course, it was demand of the time, and it was tried out, and it helped to save billions of the people to feed. But now there is more realization that this approach cannot be sustainable. And also we need to, by 2050, there will be another 2 billion people to feed. So we need to utilize all the space available. And we need to keep our resources intact in terms of the soil fertility, health, soil nutrition, because there is a proverb, हम कहते हैं उसको, जो खेत में है वही खलिहान में आएगा. So over the period, we have experienced that in 50 years period, many of our food have lost their nutrient values as well. And that is even up to extent of 30 to 35%. And with climate change also, we say that carbon dioxide concentration, in case of carbon dioxide concentration, for C3 kind of photosynthesis, there is loss of protein and vitamins, and of course micronutrients as well, zinc, riboflavin. Even in rice, it has reduced by 2% with 2 degrees of temperature rise. So this is about enhancing the diversity as well, and also rotating the crops and mixing the crops in such a manner that it is kind of symbiosis. It is not a standalone arrangement. All the systems are helping to each other. So by this way, the NSIFs, the nutrition sensitive integrated farming, it adds a nutrition lens to the farming system with focus on individual households and of course the community needs as well. So where we can make best use of our commons. So next, please. Here we have an example. This is from the Swabhiman program. So, and here we can see the theory into practice, that how the linkages improved and how the diversity has improved. And in this process, the monitoring, we have tried it out with more than 3,500 households so far, and have been successful. I would say that 72% around. So households, there have been very positive results. So where the dietary diversity was 2 to 3 max, rice, potato, some green leaf, that's all. So it has increased by 5 or 6 over a period of 1 year, 1.5 years. And the monitoring tools that we used, that was of course the dietary maternal minimum dietary diversity score. So that we used for the planning purpose, and for measuring the outcomes, BMI and wasting, crop diversity, what is the diversity of the crop, and also for the purpose of farm monitoring, it is wheel diagram, and the cost benefit, of course, because if it is not viable, ultimately people are not going to buy the idea. And in this process, we also observed that convergence is a thing which is a trigger. If we are able to set up good convergence, like in this case, there were vermicompost and other inputs mobilized with the help of UNICEF, and this helped a lot the families. Even NREG, Manrega, and skills and practice. If it is skills are in practice, once the skills are transferred and it is not practiced, then it is of no use. But if it is in continuity, then of course it is very impactful. And for this, we need a cascade of the resource pool of local community volunteers who can demonstrate it in the field, who can transfer the ideas and practices. And the disablers, the patriarchy itself is as it reflected in most of the presentations. And next, please. So we must say that home-based production, this is the most reliable source, home-based or commons. This is the most reliable source of diverse food availability at household level and for the mothers as well, for maternal diet. It helps the family to identify the gaps, that what are the food groups missing, and then they plan with their local varieties, local species, that which things we can introduce. And many of the institutions come forward there. They can be helpful in like KVKs, so they can, or even colleges who have nutritionists there, they can guide the process that, okay, these are the species, local species that you can try out in your fields. So by this way, they will be able to diversify it. And it, of course, varies district to district. We are talking about the states, but it is the fact that we are living in a country where every 10 kilometers, the water and the food gets changed. So we have different recipes, different diversity, I would say, ecosystem. So everything gets changed. And it starts with immediate, when we start the idea, we should start with some immediate plans, like what we can get within a month. So if we start with this idea, there is kind of encouragement and belief within the families that, okay, I am at least getting this 4 days or 5 days in a week in my kitchen. So that motivates them further to take up the idea. And kind of plant species which have been promoted much in these areas, like moringa. So because it can help perennially, banana, papaya. So these kind of perennial crops also, once it is planted, it is over. You have to take minimum care of these trees, and they will give on regular basis something at household. Next thing is that the experience shows that this has been able to improve the stunting and the thinning, wasting, and the BMIs. And one more thing is that we were talking about the toxic effects of the food, because what people are growing now, they are not eating, and what they are not eating, they are growing. And so this toxicity is reduced in case of nutrition sensitive NSIFs, because external inputs are used to the minimum level. This also helps to regenerate the ecosystems and sustain the level of the production with our diversity. And the nutrition sensitive NSIFS approach can be well used for preservation of some of the species which are uncultivated. Uncultivated means these are naturally available in our surrounding. We never planted them, like in the forests or the mushrooms, whatever we are getting from the commons. So if these two are linked for conservation purpose as well, because many of the species we have lost over time. And there are many hotspots and studies which confirm that we are losing our common food. And there was a time when we had almost 40% of our food platter filled with these free foods in rural communities. And particularly the undernourished families that we are talking about. So, and finally, it can be customized. It can be customized. As I earlier said that my and your farm can never be same. So there are some medium farmers, there are some landless families even who have only house. So what they can cultivate on the roof, like we are talking about urban agriculture. So there are some or other kind of produce. We can add diversity to the maternal diet with use of NSIFs. Thank you very much.
Thank you so much, Krishnakant. This was quite unusual, quite unlike what we would normally hear, and it was very delightful to get insights into going back to the roots, if I may say, like, to where it all begins. And just one question to you before we move on to the last speaker on the panel. Did you have any challenges at all in this? I'm sure you must have, because it's in a very different way, it's a behavior change. They will always say that this is all we are growing. This is what we've been growing for years together. Now, don't come and tell us any changes. Was that kind of a friction there for a large part of the start of this initiative?
Many. For few examples in very brief. One, it is when we talk about the inclusion or gender, right? So there was a particular month and we had a meeting in the community. We said that, okay, look, these are the plant species which are very useful and nutritious. And we should plant it in our households. So are you willing to try it out? Everybody said yes, 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 yes. So we made the list. So 5 plants every household, we totaled around 200, right? And next day, 200 plants were delivered in the village. And for next few days, everybody was absconding. When we came to the village, everybody was running out. What happened? Why had not you planted it? And nobody was there. Then we had the meeting with the women and came to know that there is a belief that in this particular month, if we plant anything, so there will be death in the family. So they opposed to it because we were trying to impose, and it was in the meeting only male were present. None of the female were present because it was a fasting day. So everybody said yes, because they were getting the plants, and then they forgot easily about the implications. Then what happened? Then we said that, okay, but we have the plants. What will happen then? They said that, okay, let us find out some elderly. They can plant. And they started cursing us that, okay, we are the simple scapegoats, that because we are elderly, you want us to die. That was one. Second, it is in the convergence process that sometimes it happens that the inputs are delayed. So when the inputs are delayed, in that case, the farmers or families, all efforts are wasted. So this is a gap. And third, every time it is to keep the quality control. What we are communicating should be, streamlined, and there is no communication loss from the, I would say, idea to practice level.
A huge congratulations to you, Mr. Krishnakant, for this wonderful effort. Before we move on to Sujit, there have been 2 times a question about Moringa being asked, and we are aware that that will improve the anemia status of women. There were some groups, I think American Indian Association did try that out in the geography of Andhra Pradesh, as far as I'm aware. So what is your take on Moringa, anemia, pregnant women, and connecting these dots?
Moringa, for 2 sources we prefer. One, it is the calcium, because it is very high in calcium. And of course, the green, I mean, the dark leafy green vegetables are always good for anemia control. And I leave this on discussion of the nutritionists, because there is a panel. I mean, a lot of nutrition experts are there. I'm not expert into that. But yes, of course, I found it that it is useful because it has 3 produces. One is the leaf, second is the flower, and third is the fruit. So all the 3, likewise, I mean, when we are talking about to strengthen or add muscle to this, we should also think about the recipes and the use of different parts of the same plant species. Right. Because there are some states which are using most of the parts of a plant. They don't leave anything. And they were mostly the drought hit or the famine hit areas. Right. Because their practice evolved that they make a recipe out of everything.
Yeah, okay. I think there are some research papers on Moringa. That is why the group, which is constantly trying to address the research gaps, has posed this question. We will surely brainstorm and apply our minds on what better and what more can be done to totally explore and exploit the nutritional value of every part of every plant that could be grown easily in our context. So thank you so much again. So last of all, it's my pleasure and privilege to welcome Mr. Sujit Lingala. I've read about how you made many millions of eggs available to many in a community by your fantastic business model, Sujit. And, even when we say vegetarians, non-vegetarians, definitely in India, even the vegetarian pregnant women will suddenly start eating 1 egg a day. That is the mindset. So we have to encash that better, and we want you to tell us how egg as a nutrient can improve maternal health and diet. Is it a simple quick fix solution that we can give? And also Vidya Togi spoke about the adolescent age group, and I'm aware that you have done impactful advocacy on adolescents in the community who can be the change makers. So your brief, Sujit. Welcome.
Great. Thank you so much, Dr. Divakar, for this introduction. And this has been an absolutely fantastic 2 hours for me. I've been frantically taking notes. Such great insights. So thank you so much. Let me start by, you can go to the next slide, Rajni. Thank you. So a small but mighty egg, in fact, like how Dr. Divakar mentioned, provides nutritive support for the growth and development of the human fetus during the pregnancy. And in fact, eggs provide a balanced source of energy and protein, as well as essential fatty acids. And in fact, a wide range of vitamins, minerals, and other bioactive compounds that could improve nutrition during pregnancy and also birth outcomes. And what's more, they're extremely versatile. They can be cooked in many ways, eaten any time of the day, and it lends itself to, a traditional meal, also a modern meal, and it's immensely liked across age groups. So we can go to the next slide. But nevertheless, their consumption specifically in India, like we've seen in many presentations before, especially in rural India and the last mile, is extremely poor. And while India is in fact one of the largest producers of eggs in the world, production is concentrated only in a few South Indian states, and most of northern and central India and the rural areas suffer from a stark deficit And this leads to very low availability, high prices in the rural areas, and usually by the time the eggs come from the south to the north, they become stale. They're almost nearing their expiry date, so it's very difficult. And in fact, if business continues as usual, studies reveal that egg availability in rural India is in fact actually very less, at 2 eggs per person per month, and by 2030 it will reduce to a half. So we will have only 1 egg per person per month by 2030 in rural India, and therefore there's an urgent need to scale up the egg production with sustainable solutions that can in fact reach the last mile. We can go to the next slide. So I will use the next 5 minutes to throw spotlight on 2 such interventions, which we found can improve egg consumption. First is, as you can see on the left, a cooperative, all women-led cooperative model that has succeeded in increasing egg availability in the communities by 4 times, reduced price of eggs by 30%, and increased family incomes by 8 times. And all this while simultaneously empowering their women partners. And second, on the right, is an initiative to create tasty, nutritious, accessible, and affordable egg powder-based products for the last mile that are aligned with consumer insights and aspirations. We can go to the next slide. So I'll talk about the cooperative model. Next slide, please. Great. Before the egg production, or before the cooperative model started in the intervention areas, the model started in Anuppur, which is a district in Madhya Pradesh. The families subsisted on rice and occasionally complemented with edible plants foraged from the surrounding forests. And not surprisingly, malnutrition in these communities was very high. Approximately 70% of the women in this district were anemic and 33% were underweight. We can go to the next slide, please. And recognizing this opportunity, in fact, MPWPCL, or Madhya Pradesh Women's Poultry Production Company Limited, pioneered a cooperative model for poultry farming with about 600 all women farmers. And most of them belong to vulnerable communities who are engaged in manual labor or wood collection before the establishment of this cooperative. And interested women who have expressed interest to join this particular program were organized into groups and provided training in poultry rearing and management practices. And once the training was over, these women were provided with loan and grant for the poultry operations. And each woman started with about 400 chicks, and 20 to 25 such sheds were located within a very tight cluster. And what this model has enabled is for the cooperative to achieve cost efficiencies. So any, like, your chickens or your feed or your vaccines and medicines, if a small farmer had to pick that from the retail market, they had to pay a huge price. But since it's being taken in wholesale by the cooperative, all those production efficiencies could be passed on to the farmer, and they could, all of that resulted in higher income. We can go to the next slide, please. And a very small size plot, around 340 square feet, has improved socioeconomic and nutrition conditions of these households by increasing the income 8 times. And women can now feed themselves and their children an egg every other day, while at the same time, they have been able to nourish their own communities with the increased egg supply. And models like MPWPCL's cooperative poultry farming have been very highly relevant for women who cannot enter full-time jobs, or mainly because of the household chores, and also because women have negligible ownership of arable land. And because of this, this poultry cooperative model and raising chickens, 400 to 500 chickens in a 350 square feet plot has been extremely helpful for the women. And the beauty of this model is that local production meets local demand, and this in turn creates a virtuous cycle of nourishment, women empowerment, and at the same time poverty alleviation. And this model has been proven to be sustainable and scalable. And MPWPCL is right now very well poised to expand this successful and proven model to serve marginalized communities in other states as well. They're looking to expand to other states, and it's exploring opportunities to set up better infrastructure to help reduce costs and increase access to the communities. And in fact, by 2030, it aims to empower about 25,000 women to pull themselves and their families out of the debilitating poverty and malnutrition. So this has been one extremely, extremely useful model. We can go to the next slide. And so that's been about a cooperative model. And second, I wanted to talk to you also about egg powder. And most of us might not have heard about egg powder, but it's a pasteurized spray-dried product from fresh hen eggs. And its production process is almost similar as for powdered milk. Egg powder has in fact been heavily utilized in institutional settings, not in our households for cooking, but it's heavily been utilized in institutional settings for hotels, hospitals, restaurants, military establishments, and as well as in bakeries and cake mix manufacturing. Next slide, please. In fact, egg powder has significantly more advantages compared to the whole egg because specifically in the rural last mile settings, because it has an extended shelf life. It's cheaper. It's the ease of transportation, storage and usage is much higher. And moreover, in the ongoing pandemics that we are in right now, fresh food supply chains have been very fragile. We've been in lockdowns. It's very difficult to get foods from various other states, and eggs have been under a lot of egg supply chains have been under a lot of pressure. In such situations, and also when during the pandemic, when nutrition is of most importance, egg powder can play a very pertinent role. And but however, it's like I said, its use in household settings is almost non-existent. It's not there. Next slide, please. Yeah, so Sight and Life, like I said, it's a technical and knowledge organization that looks at innovating for malnutrition. We have initiated the development of tasty, nutritious, accessible, and affordable egg powder-based products for the last mile. And for this particular project, we've been awarded the Grand Challenges India Award and also have been very thankful to be partnering with St. John's Research Institute and the government of Karnataka for this work. We have just completed preliminary consumer insights for us to be able to determine which foods to develop. And I'm very, very excited to share those very few insights with you. It's very exciting. We interviewed pregnant and lactating women, mothers of children under 5, to get insights on what their food habits are, what are the food formats they consume at homes, what is their perception of eggs and packaged foods. And what we gathered was very heartening and reaffirmed our belief in the power of eggs. I'll take you through a couple of them. What we realized is for a mother, ability to add personal touch to food is so important to her. And therefore, we are in fact targeting one of the food formats for children to be a porridge, so that it requires her to add that water or milk and prepare it and mix it before serving. That's kind of like, able to have her add that personal touch. And second that we've realized is pregnant and lactating women during the course of the day, they know that, you have to eat more food, you have to eat more eggs or increased diet, but they don't prepare specific foods for themselves during the main meals. Usually they eat whatever is eaten by the entire family. Any extra effort is in the supplementary form, such as, they'll cut fruits, they'll drink more juice, they'll soak seeds and eat them. And that's why we're targeting snack moments for pregnant and lactating women, like including biscuits with egg powder and extruded snacks. And one other thing is that eggs have been widely loved across our interviews, and they've been seen as very versatile form of both traditional and modern meals. This is a clear win for introducing egg powder. And meals are, and we've asked them, what exactly do you want in an ideal packaged food? And it's, I tell you, it's a very tall order. They say it should be of good quality, it should be easy to prepare, delightful to taste, visually appealing, fun to eat, and nutritious. It's a tall order, but with our star ingredient, the egg powder, and very supportive collaborators and donor partners, we are confident of achieving it. Next slide, please. You can go to the slide before this, sorry. Thank you. As a result of these insights, we've been able to develop 4 product formats: porridge, nut butters, extruded snacks, and biscuits. And we'll also fine tune based on acceptability studies and further consumer insights. And you should start seeing these products available in government channels, NGOs, and retail settings beginning Q2 2022. So please do stay tuned. And that brings me, you can go to the next slide. That brings me to the end of the presentation. And I want to leave you with this thought. Women living at the last mile struggle to access nutritious foods. Eggs are an extremely nutritious and versatile solution. And being able to identify and scale innovative and lasting interventions like the ones above, and the ones that bring eggs to the last mile, will make mothers and babies across India healthy. I will also share a few relevant articles that I used in my presentation in the chat box. And Dr. Divakar, over to you. Thank you.
Thank you very much. This looks like a low-hanging fruit for us because it is so feasible, so doable, and so scalable. Any other thoughts on how the maternal nutrition, with so much diversity happening, so little time that the clinicians have, the touch points are many through the life course. Okay, it's not only the maternal nutrition, but right from the newborn all the way up there. So is there something which can be applicable as easily as the products that you have just mentioned? Can any of the age groups benefit from this?
Yes, thank you, Dr. Divakar, for that question. Eggs are not just for pregnant and lactating women, it's across the age groups. And there have been many studies, in fact, showing how egg, given as a complementary food for children under 5 has been showing extremely, good results in reducing malnutrition. It's also been very helpful for adolescents and also for all of us, adults as well. So egg is a powerhouse of nutrition, if I may say so, and it's for every one of us.
Yeah, thank you so much, because one simple takeaway is that, yes, we require a lot packed into one. And as you said, the nature has very cleverly, very beautifully packed it into this. And we need to pay more attention to proactively telling them that, because like the papaya story, there may be misconceptions about the intake of eggs as well, that whether it's too much heat and premature deliveries and this, that, and the other. So the women gets, totally confused and psyched up. So a common uniform message that it is so worth it is really a simple but effective message from your deliberation. Thank you so much, Sujit. Now over to Rajni and team NIN, who every single time that we have the e-dialogues, last Friday of every month, they are here as our strong support and solid backbone to tie up all the loose ends and get us to discuss with such an interesting mix of insightful information. The gaps are surely going to be bridged with this meaningful exercise. That is my resolve on behalf of everybody who is watching this program. And Vani, Bhartiji, Rajniji, Sebanti, and the entire team, and the very distinguished panel, thank you very much for making me a part of this. Namaskar.
Thank you very much, Hemaji, for conducting this panel discussion in a brilliant manner. I'm sure all our audience and participants would agree with me that this has been a very brilliant session altogether. We started with very wise remarks by Dr. Sheila Veer, giving us the historic overview of how the supplementation program started. We also have heard from Dr. Neena Bhatia about the Poshan 2.0, which is very important at this junction. Then we had very informative presentations by Dr. Tina Sangvi and Dr. Fuang. Dr. Tina mentioned about the strategies and how diligent execution is the key. Dr. Fuang gave very nice insights from her work in the Uttar Pradesh. Following that, we had a wonderful panel discussion, which took us to the solutions, potential solutions to the problem, because we all know that maternal diets are suboptimal. Radhika gave a brilliant presentation with all the principles behind balanced diets for pregnant women. Then Dr. Shobha mentioned about the clinicians' problems, and these are real problems because she said that clinicians don't have nutritionist help, and then it's very heartening to know that nutrition education modules are being developed. And then we heard two unusual presentations for some groups, for the obstetricians and from nutritionists. And Dr. Krishnakant's experience of the Swabhiman program was very enlightening, especially in the rural context, how within the available resources, a family can get nutritious foods, which is meeting their demand, was very, very enlightening. And finally, finalist Rujit's presentation about egg, because egg production has been increasing substantially in India, but the consumption is not meeting demand. So the Madhya Pradesh experience of cooperatives was very enlightening, and the egg powder also, because it's very helpful for the last mile delivery. Overall, it has been a very, very enriching webinar, and we heard from many, all our presentations. We heard from our speakers and panelists different viewpoints, and we are very grateful for them, very grateful to them for sharing their time. I would request Dr. Sheila Veer and Dr. Neena to give their quick concluding remarks.
You want me to start? Yeah.
Yeah, please.
Okay, thank you. Thank you. It was a very excellent presentations on global perspective, followed by Indian scenario and enablers and barriers, and then NIN presentation and Dr. Dobi taking us to Krilish's role. And then we came to something which we call, which should be Diet Plus. So it was our presentation on farm resources and how it could be linked, and also the a detailed and a wonderful presentation on poultry cooperative model and egg consumption. I would just like to be brief here and say that yes, maternal diet, what came out from this presentations, which I always think, how do we go forward from here? And I would restate that I think we need to, in Indian context, I think the first thing we need to do possibly is do some simple things which are doable, like BMI linked weight gain promotion that was mentioned by Dr. Radhika, but I think we need to disseminate it very fast. Supplementary nutrition, we need to also, expert group need to debate on whether it should be universal or we should targeted, because we also have a lot of obese and overnourished or overweight women in some of the states is as high as 40%. How do we solve that problem? Safety issue was also mentioned by Tina, and also I think program use of platforms was also stressed on. And I think we have to take then that context in antenatal context and how that could be used, how we could start weighing the mothers, which we don't do in the program context. I think these are they sound simple, but we have actually, I'm sorry to say, but we have ignored maternal nutrition, except for supplementary nutrition, which is gaining momentum, but we don't have evidence based. Let's put evidence together that it makes a difference in the current scenario. I remain concerned about the future. And in that context, I think we have to move beyond only ICDS to role of health sector, role of NRLM, because when we talk of Nutrition Plus, very well brought up by Dr. Kant, of the role of women's collectives and how they enrich the food diversity. Only one request to NIN, Dr. Radhika, that yes, very good regional diet charts and diet details that were presented. I was concerned a wee bit about the cost also. And I think sometimes when we take such regional diets in our messages, they get lost because they are not, when it was shown by the UP study by IFPRI, that wasn't working out in the sense that people could not afford it, they did not buy it. So I think we need to be realistic, and how do we make it more principle oriented along with the regional diet? I think we need to simplify it. And has it been field tested, those regional diets which were mentioned, have they been field tested? What has been the acceptability? I would be interested to know, and maybe Dr. Radhika, you can communicate sometime. And I think role of private sector came up with the role of clinicians, but I think we need to also, in the industry which employs women, we also need to see how pregnant women are looked after on the maternal nutrition side. And as it was mentioned by Tina Sangvi, I think it is diligent execution that is very important. With these few words, I request the group which has organized this meeting to form a task group and go forward with guidelines and on policy, which will help in formulation of policy on maternal nutrition, which is missing in our country. Thank you very much.
Thank you so much, ma'am. Dr. Neena, any quick concluding remarks?
I think Dr. Sheila has already summed it up so beautifully. Just one more request that when we are counseling pregnant women, we should also, try to involve many more nutritionists and make sure that individualization that we talked about, happens, and how we can, maybe some experiments other than the, which where individualization of dietary advice at the program level, if there is any evidence, like, because right now what happens is usually if you give something and you will withhold something from someone at the community level, it can cause certain problems. But I think I've been part of journey of many of the things that were shared, and it was very interesting. My heartiest congratulations on organizing such a wonderful program. And I think from we started with diet diversity, but we talked about crop diversity, and we talked about so many things, and that was really, really brilliant. Thank you. And it was a great learning and, a lot of ideas. So it is wonderful to be here. Thank you.
Thank you so much, Dr. Neena. I once again thank all the speakers and panelists for brilliant presentations, and thank the participants for engaging with us, although we exceeded our time by almost 1 hour now. Thank you so much for your interest and engagement. Stay tuned to our next webinar on maternal anemia. We would be announcing next week soon, and please participate for all our wonderful webinars. Thank you so much.
Thank you.
Thank you.
Thank you.